This is a chart showing the typical systolic blood pressure in young girls starting at 1 year of age until they're 17. And this line shows the bottom 5%, young girls with the lowest acceptable blood pressures. Anything lower than this would be considered hypotension. This is how most pediatric blood pressure guidelines define hypotension, below the 5th percentile. But here's the thing, blood pressures vary not just by age, but also by height. Let's include blood pressure data based on height. This top line shows the 5th percentile of blood pressures in some of the tallest girls at this age. This bottom line shows the 5th percentile of blood pressures in the shortest girls. You can see there is around a 7 millimeter of mercury difference between these numbers at a given age. If we quickly flip to boys, we can see that the range is even wider, hitting almost 9 millimeters of mercury at a given age. It's a pretty substantial range. Now, these percentiles are what the scientific data shows. You'd probably expect the blood pressure guidelines to align pretty closely within these lines here. Well, let's see. Here's how hypotension is defined by the Advanced Pediatric Life Support Guidelines, or APLS. And here's how hypotension is defined by the Pediatric Advanced Life Support Guidelines, or PALS. It's the most commonly used guideline in North America. And let's flip back to girls. What we see here is that the definition of hypotension, the 5th percentile of typical blood pressures in the population, isn't aligned very well with the guidelines. For almost all ages under 10, the PALS guidelines are completely outside the systolic blood pressure range of the 5th percentile. And this isn't limited to just APLS or PALS. Other guidelines put out by the Brain Trauma Foundation and the International Pediatric Sepsis Consensus Conference have similar issues. This chart shows another problem. Not only are the guidelines not aligned with the blood pressure data capturing a patient's height, but none of the guidelines are aligned with each other either. What guidelines do you follow? Which one's the most accurate? Clinicians often have to make critical decisions when using hypotension guidelines, like when to use vasopressors or when to administer fluid resuscitation. If we can't all agree on how to measure hypotension, then patients might not get the treatment that they need when they need it. Things get even murkier when we start using different tools to measure blood pressure. All the data we've shown you here is based on measuring blood pressure through auscultation. But we know that blood pressure measurements vary quite a bit between invasive, automatic, and manual means of measuring. Get subscribed to our YouTube channel or follow us on our mailing list because we're going to open up that can of worms in an upcoming video. So as a clinician, does this matter at all? Would this change how you might care for patients in septic shock or who have increased intracranial pressure? Let us know what you think in the comments below or on the Figure 1 app. We'd love to hear your take on it.